Their ability to take massive amounts of data and be able to funnel it down into the top 10 or top 20. It's not perfect, but there's a saying now in the analytics space of 2 + 2 = 3.9. It says close enough is good enough. And that's fundamentally where we're going to get because of the amount of data that's actually out there. We're talking about exabytes worth of data. And so just to give you a perspective on the size of data, not to go on a tangent here, but everybody's probably had a CT in the room. A typical CT takes 50 megabytes to put a study out there. We now have 320 slice CTs that do 20 gigabytes worth of data. So you see this huge amount of extra data that's now being poured in. Then you have, which by the way has 2,000 metadata elements associated with it, with that particular study. Now you take DNA that gets in there. DNA is 130 gigabytes to do my sequence. And so all of a sudden the amount of data that gets in this thing, it's not going to be the data itself, it's the metadata that's attached to it. It's what that thing is about and what information we can capture. And then we can do all this cool analysis to help the doctor at the point of care. That's the game in the future because there's so much data that's being produced. Who can organize it?
The only thing I would add, and perhaps Joy might be addressing some of the policy aspects, you know, this new way of delivering care, the regulatory frameworks that are necessary, a lot of dialogue going on right now on regulation of medical apps, not to mention, you know, the more traditional electronic health records. The reimbursement issues, as you stated, are huge. We still don't have, we're still not far enough along in terms of getting reimbursed for remote monitoring. Big, big problem. And the policy framework, the privacy framework, how to assure security. And so it just, as this revolution accelerates, you know, building flexible regulatory and policy frameworks to take into account the changes, I think, will be important. So folks feel comfortable.
How do we get there? I mean, how do we get there with the incentives and the payment, and how do we get it so we have people with some clinical background and technical experience to do things with the monitoring? Is it the ACO model where essentially the organization financial risk is also the organization that takes care of the patient, with the police, in a sense, being the quality and access reporting measures? I mean, how do we get there? ACA, no ACA. We got to get there. Is there a way we get there? Is there a couple of paths we get there?
It's a tough question. You know, we've said it before, it comes down to making an organization or some entity, whether it's an accountable care organization or whatever, responsible for that full care. Somebody has to take responsibility for the health of a defined population. You know, other countries do it by having nationalized systems where the system itself is responsible for the health, and they allocate resources in a way to maximize the health of that population, and some do quite well, actually. You know, if you look at our rankings in terms of health outcomes relative to many Western Europe countries who spend a lot less, who allocate funds in different ways, but I mean, that's sort of a simplistic answer. How do you get there from here? I mean, that entails a lot of winners and losers in the system. Your providers are going to be, your physician providers in particular, are going to be much worse off under that kind of environment. If you look at the pay of physicians in most Western European countries, they'd love to have our system because they want to make more money, and that's going to be a resistance point. So politically, I don't even know how you, I don't know how you get from where we are to where we have to be at this point. But
I'm not sure all the physicians will be losers. I mean, I think pediatricians will be winners, yeah, because they're on the bottom end. Cardiologists will be losers. Surgeons will probably be losers in that environment. But you know, we have close to 60% of all physicians today are employees, so we're kind of getting there.
Yeah.
You know, And so a couple of things. Some of the pilots that CMMI, they're performing, some of the innovations will fail and some will succeed. And the good news is there's a good amount of funding there to figure out what works and what doesn't work, whether it's shared savings or bundled payments or bonuses on top of fee-for-service and the like. And so we'll learn, and if things hold up with the law, they're not required to go back to Congress to move them out on a broader scale. So that's one. But the other thing I've been really impressed with is the number of health plans, large and small, that are also experimenting with these models and collaborating in new and different ways with clinicians to get there. So I'm optimistic that we'll get there. It'll be a little bit rocky, and we need to learn as we go, probably at a faster pace than we have in the past when pilots have been conducted. But it feels like there's a lot of energy in the private sector. And we don't have any choice, by the way, because the cost curve, it's unsustainable. We're in trouble real soon when the funds run out.
And ultimately, corporate America has a lot at stake here. And if they get behind, you're seeing growing interest in worksite wellness and things like this. Again, we've been talking about it for 30 years, but now we're starting to see some traction as the employers are looking at the bill that they're spending, a substantial proportion of labor costs have to do with providing health insurance. So if they can find a way for their defined population to get people healthier, not only do you cut your healthcare costs potentially, but you also have less absenteeism and greater worker productivity. There's all these secondary benefits. It's, if they get in a big way and they will really change the incentives for their workers. They'll give people, a stronger reward structure for being involved in healthy lifestyles. And then the technology just enables them to do that in a meaningful way. I mean, I'm frankly kind of excited. One of my running buddies has a little patch that is enabled with a GPS or something, and at the end of the run, she knows how far she's gone, how much altitude how much up and down. It monitors her respiration rate, her heart rate, gives estimates of her calories burned on a more accurate basis. It's really exciting, but doesn't, that's sort of a novelty thing. But I mean that's an example of the kind of things that we do for. For healthy people, it doesn't matter. It doesn't going to affect her health status and her use of healthcare system. But if you put this application into sort of the average person, I think you're going to get the same kind of information.
I could add to that or see a model that could be built around that. I mean, the insurance industry is putting stuff in cars, say, are you a safe driver? That same patch, you could say, hey, I'm going to go to my payer and say, I've been running 25 times a month or something like that. Lower my rate. And you're starting to see classes of people get, I don't know about healthcare, but you're seeing it in other industries, and we usually are about 10 years behind, that all of a sudden you can adopt that same process and say, hey, I want to insure the healthy people. And you could see that model actually getting blown out a little as to what you actually do on a day-in, day-out basis.
Yeah.
I mean, it sounds like everybody at every level's got skin in the game to make those changes.
Kind of like Amazon Prime for healthcare. You get free shipping in Amazon Prime, so then I get a lower rates on things. And maybe I get discounts on my clothes or stuff because I'm in better shape, and coupons.
I don't put anything out of the realm of possibility these days.
Well, but that creates the adverse selection problem. I mean, you're going to get insurers then going after that healthy segment of the population, and because you're going to end up with people who are going to essentially be uninsurable, because of lifestyle or because of bad genetics or bad luck, I guess, any one of a number of factors. And so the problem won't really go away. It'll change a little bit. We'll probably get better health care for the high-end people, the healthy people, and maybe the middle, but we're still going to have that group of individuals. I mean, some people, because of that, argue for single payer, put everybody in the same pool, then you don't have the adverse selection problem, but that's a political quagmire.
So your point, 51 million and growing.
51 million, yeah.
Well, the whole concept of insurance is the fact you put everybody in a pool and, you hope that, if something happens, you're covered. For example, to make this point, is there anyone in this room that has life insurance, is looking forward to getting paid off on it? Really? So how many of you have health insurance and you're looking forward to get sick so you can get paid off on that too? No. So you see, it's funny the way we think about healthcare. I mean, a lot of times we think of healthcare as kind of this goodie bag. We get to see the doc, we get our teeth cleaned, whatever it may be. And we kind of say healthcare is good, the more healthcare is better, right? But that's a cultural thing. But we don't think of life insurance the same way. Like, let's go execute my life insurance, no pun intended. So there's a cultural shift. Don't we kind of need a cultural shift in healthcare where, if I got 1 CT, 2 CTs must be better. 3 CTs is kind of like a triple, 4 CTs is really great. It's equal to 400 plus x-rays, chest x-rays, but it's different. Don't the public have to change a little bit in their thinking? Or am I way off base?
Well, my comment about skin in the game, I mean, there's certainly more opportunity for personal responsibility, smart personal responsibility.
I'm a big fan of 4 CTs because we're a big storage company, but no. But I'll give you a real example. EMC's had a personal health record for their employees for over a decade now. And so to Jerry's point earlier, we are now forcing conversations to our employees. And what I mean by that is that we have to fill out a health risk assessment every year as part of enrollment or the benefits side of the house. And basically says, hey, you get $12 off your monthly payment if you fill out this health risk assessment. If you don't want to, you're paying an extra $12 a month. Everybody signs up for the thing, right? Half people probably lie, who knows? But the point being is that we're aggregating that data. And what we're now doing is working with our payer and working with the local hospitals. And to get to the duplicate studies aspect is we've lowered our health insurance costs by 17%. And we've done that by doing things like looking at the top drugs that our employees are on and putting wellness programs to put out there. We've done the duplicate studies aspect. There are organizations like CareCorps out there that actually say, you can't do that anymore. You cannot, we're not paying for it. And so they have to have a clinical relevance to have that second and third and fourth study done. And if they can't prove it, they're not paying. And so the conversation is now starting to shift from providers are right, and trust me, I work for providers, they're usually right. But the payers and the employers are now starting to say, the heck with this. We're going to take ownership to this data, and we're going to control the conversation. We're starting to see models be built around that philosophy out there. An example, organization that's really conversation.
Anybody have any questions? Let's have a question here. There you go.
So what you just said about the employers getting into the decision-making on the health care of the patients is really interesting, because what it effectively does in some ways is it puts the patient in the position of having to confront the doctor a lot. So when the patient's had the test done, Dr. A, the patient goes to Dr. B, yep. And Dr. B wants to reorder the same test, even if they have the results of the test, the previous test, right in front of them. Yep. And now the patient's the one who has to say to the doctor, I'm not doing that, because if you do that test, they're not going to pay it. Yep. And if the patient doesn't have that conversation, they're really on the hook. But they feel like, I think that is creating this essence of distrust between them and their doctor, and it's a really awkward situation for them.
Sure is. No question about it. And I'm a real example of that. I had some medical issues that I went to MUSC in South Carolina. I went through a battery of tests, and they were going to provide surgery, and literally no more than a week later, I went, actually less than that, I went to Cleveland Clinic because I didn't like their recommendation. I wanted to find the best of the best. And he did the exact same tests again.